Charles Darwin, a guy you've probably heard of, talked about change a little bit with evolution and said it's not the strongest or the most intelligent who will survive, it's those who can best manage change. Is this a time of change in healthcare? And I saw there's a lot of non-physicians in the audience, so what I'm going to try to do here is to give, at least as best I'm able to, my perspective and that of the American Medical Association's on the context within which change is occurring and where digital health fits into that, and where the two things can complement each other, and where are those things that we have to be a little bit careful about so that we get the good and hopefully don't create some bad things we don't really want to have. So first of all, current politics. The SGR formula, which was the flawed way that the United States government paid physicians through Medicare for well over a decade, finally went away on March 31st, April 1st this year. And I'm not going to go into all the details of that because it's not probably directly germane for a lot in the room, but it's important to mention because with all the uncertainty every year of not knowing what your pay structure was going to look like, whether it would go up, whether it would go down, it was almost always flat or essentially flat or beneath inflation. It was utterly impossible for people to really plan a business model and look forward and say, we want to move on and adapt new payment delivery structures when you were relying on this legacy model that was forever burning and unstable. So the fact that that is gone, I think everyone in this room who works with the healthcare delivery system needs to know is really fundamentally and foundationally important. And so now that allows us to turn our attention far more solidly to the new payment and delivery models that everybody in this room, I think, would agree we need to undertake. It probably won't solve a lot of these problems like we hope it will be, but it may make some of them better, and that would be a big accomplishment. And it's worth doing, and it is certainly this generation's current opportunity and challenge to try to incrementally move the ball down the field a little bit more and make it better. So then pivot to the Affordable Care Act. Again, I'm not going to talk about the Middle East or the Levant, but I will talk about non-controversial things like United States politics. And in that arena, with the Affordable Care Act, a piece of legislation, a law, that for the last 5 years the country still has not kind of normalized and embraced collectively and moved forward. But it's undeniable that it has changed things. And I would assert that it's changed some things very much for the better. I know people can, statistics, there's lies, damn lies in statistics, right? But I mean, most people think there's probably over 10 million people who now have health insurance that previously did not. It is an enormous accomplishment in 5 years in the face of unrelenting, not only opposition, but obstruction, to have 10 million more people insured in that short of a time frame. That is astounding. And so now we have people who are trying to or able to access care. Now there's all sorts of other challenges, and in Q&A or other venues we can talk about the challenges too. But getting these people into a system of care is really profoundly important. And so now take that context where we are having the most seismic changes in healthcare that we have seen, not in one generation, but probably in multiple generations, probably since the 1960s when Medicare, Social Security, and those programs were created. This most foundational and seismic change, where big change was already happening, and then now you have things like the Affordable Care Act that poured gasoline on the fire and really accelerated the change. And then take that small thing, digital health. There's no innovation going on there, is there? Not at all. None of you people here are creating the future, I bet. Every day at your desk or when you travel around the country, right? So digital health has an incredible role to play in facilitating and enabling those things we want to try to accomplish. So I'm going to use the lens of three big things, in my view, three big things the AMA is striving to accomplish to weave in a little bit about digital health and where it can play a role. So the one I'm going to choose to start with is improving the practice environment. So we really fundamentally believe that, like in any other industry, a happy workforce leads to a happier customer. And I'm not just talking dollars and cents here, I'm talking about physicians in practice doing good work for patients who need their care and their help. Right? Do any of you have a physician? We'll do a little audience participation. Anyone here have a doctor? Do you find your experiences better when they're happy? When they're grumpy, is it fun to go there? It's probably never fun to go there, but anyway, so happy doctors will lead to happier patients. And what I will say is we did some work with the RAND Corporation in 2013. Fundamentally, it was a really expensive and sophisticated research study to find out what makes doctors happy and sad. And we found out, and this should be reaffirming for all of us, particularly for someone like me who is a practicing emergency physician, that doctors are most fulfilled when at the end of the day they feel the work they did helped their patients lead healthier, happier lives, and that they were supported in doing that work. And that last part's important. We're supported in doing that work. Because most physicians these days feel very besieged and unsupported. They feel shouted at by everybody, do this, do this, do this. The only thing is, and then when they don't do it, they're castigated for not being team players, for not participating in the need to change, when in fact, there's such a cacophony of conflicting priorities being shouted at them that there's no hope in the world to do those things. And so it's a misuse of the language to say that it's their fault, partially, perhaps it is, but it's more of a mistake to say it's their fault when they can't succeed in that environment. So we also did work with RAND, we partnered again just most recently to see how physicians are responding to new payment models in their practices. And to build on the theme I just mentioned, one of the better quote lines that came from a physician was, it's like 50 people shouting their priorities to you at the same time in trying to find a way to make sense of that. So now when I talk about things like the SGR being gone, there's more than enough complexity of work that remains, and I would assert having the stability will now enable us to put a lot more bandwidth to trying to get that stuff to work better. So one of the things that we found, though, apart from what makes them happiest in providing good care to patients, is what makes them, it's beyond sad, is actually kind of irate and really enraged. And that's their electronic health records. So nearly universally, not entirely, there's always a doctor or two that raise their hand that they like what they have, but nearly universally when I do audience participation in a doctor group, they hate their electronic health records. So do not raise your hand now if you're an EHR vendor. That would be a bad time. They hate them. But you know what? More than 80% of them do not want to go back to paper. Who could dispute that managing a fifth of the United States GDP with a paper and a pen makes any rational sense? Right, no one in this room. So we have to make the transition. And you know what? I and my colleagues want to make the transition. I can't source the publication off the top of my head, but there was one in the last couple years that described physicians as digital omnivores. It would really be a misrepresentation to say we don't embrace and adopt technology. Just off the top of my head, you know, smartphones, tablet computers, e-readers, we adopt those things before other people overwhelmingly, probably because we have the education and the economic resources to do so in large part, but we embrace that stuff quickly. How about CT scanners, MRIs, PET scanners, ultrasounds? How about minimally invasive Da Vinci robots? How about genomics? We use technology as voraciously as any, and arguably more so than most. EHRs are technology that we're not ready for prime time and do not work. Now, we can complement, and I mean this sincerely, not tongue-in-cheek, we can complement our federal government for not letting a good crisis go to waste. I'm sure Rahm Emanuel did not create that phrase, but he certainly repopularized it, didn't he? We can compliment them for really spurring the adoption of electronic health records, for accelerating the pace, right? There's no doubt. Meaningful use shoved an entire sector of the economy to adopt a tool. And now when I ask doctor audiences to raise their hands, and I travel all over the country doing this, it is all but the rarest of people who raise their hand that they are using an electronic health record. That would not have been the case in 2008. So that was an enormous step forward because of the American Reinvestment Recovery Act and high-tech component of it. Big step. So that's the good side. The bad side is not wanting to let up to $40 billion or so go to waste. There are a lot of well-intended people, and I've been on a lot of the government's federal advisory committees for this. They were good people. They are good people. They're trying hard. But through a process that was fair and open and transparent, we overreached. And a number of people tried to redesign the entire healthcare experience through one software program. Does anyone else work with EHRs? Do you have that sense? They didn't just say, okay, electronically prescribe, adopt a technology, exchange information. They said, you're going to do a transition to care document. It's going to have 26 elements. It has to be shared under all these circumstances. If you can't share it electronically, you got to print it and fax it or print it and hand it. So now you got doctors using this incredibly expensive, incredibly unfunctional technology, printing off 70-page documents and faxing it to other people. And I will tell you, it is incredibly legible. It is perfectly legible and utterly incomprehensible. There is so much garbage in those things that most of us feel that the record is not a useful tool in most of the provision of care that we do. Fundamentally, what I want, if your orthopedic doctor ever tells you what they heard with a stethoscope, you should leave that office right away. But boy, I bet they know how to use a drill and a Black & Decker toolkit and some screws and some plates to put your bones back together. Most of us want to know what the person who offered something really innovative or creative to the healthcare experience is really expert at. So we need these tools to be a lot better. Meaningful use has become a big impediment, not the good thing it was at the beginning. Now it's a big impediment. We're going to keep working with the government. They're offering some hope that there'll be some change. Probably not enough. We're going to keep working with them in good faith to try to make it better, because all of us know we need to make that journey. So I'm going to pivot a little bit here to, forgive me if I look at my watch because I do want to keep us on time. I'm going to pivot a little bit and look at a crib sheet and say that it's not just electronic health records. That's part of the problem, right? EHRs are one type of digital health or health information technology. They are not health information technology. Is telehealth digital health or health information technology? So here's a good example of something that if we can get telehealth right, if we can do it well, we may be able to bring to scale to make things that are currently scarce available to a broader number of people where they are at the time they need it with fewer barriers. All right? This is a good thing. It's a really good thing. And with technology improving, the imaging, you can Skype, you can use your iPhone for FaceTime. Obviously, those aren't HIPAA compliant, but you can use HIPAA compliant versions for a lot more money. And you can do these things. We can really make things available to people in a way we previously couldn't. But there are some challenges, and I don't want to dwell on them, but I do want to highlight them. We have a state-based licensure system that is a little challenging. Now, it is challenging in that it needs to be streamlined, simplified, made easier, so that physicians and other clinicians can provide care to people across state lines. But it is necessary to preserve and protect it because all of us rely upon state medical boards to ensure that some minimum level of competency is present in the people providing our health care. And to the extent that there is not, we rely on those boards to oversee that and intervene. In the way our federalist system of government has that structured, licensure is done at the state level. So we need to find a way to make the process more efficient, more streamlined, more effective, but at the same time, try to find a way to preserve those things that all of us rely upon for a floor of minimum competency, so that you don't just have charlatans now with the fancy technology in front of them saying they can solve your problems and selling snake oil, and you all bear the cost and the consequence for bad care. I don't think any of us want that. The other thing is there's problems, like a lot of payers don't pay for telehealth. So that we're being told to use it, why are you an obstructionist, but we won't pay for it. It's important. If it's worth doing well, and it's worth resourcing. So we've got to find ways to resource and pay for that properly. So I'm going to talk and pivot here to two other topics real quick. Our first strategic issue, they're not in order priority, but the first one I mentioned was physician satisfaction, practice sustainability, improving the practice environment. The second is improving health outcomes. There are about 100 million Americans in the United States who have diabetes or prediabetes, and there are about 70 million Americans who have hypertension. It's 170 million people. There's obviously some overlap there. It's estimated that those two conditions alone contribute to over $500 billion of the $2.9 trillion or so that Phil showed you in his presentation. If we can bend the curve on that, we could have a profound impact both on the cost of care in the United States, but also on the burden of disease, illness, morbidity, and profoundly improve public health. So the AMA is going to try to find a way to catalyze the change all of us know needs to occur, but to try to do it in a way that brings it to scale, that can have the impact that others have not yet been able to do. It's bold, and we may or may not succeed, but we are sure going to try mightily. And of course, this is at least a decade-long plan. So we're partnering with the YMCAs, we're partnering with the CDC, partnering with Johns Hopkins or Armstrong Institute to try to find ways to better treat, better identify, better manage these conditions. So consider this. There's people here from technology companies, right, or deal with technology. I see some hands. You design things, right? Drugs, devices, technologies, software. How about this? All those things have good and they have potential risk, particularly drugs and devices and things like that. How about an intervention that has zero downside risk? The only risk is the cost of paying for the program. And if you do it, you have a better than 70% success rate. Would that be an investable product if I could pitch it to you in the venture capital world? So the YMCA of America has a lifestyle modification program. If you're over 60, you participate in it, you fulfill the criteria for a full year, they can reduce by 71% the likelihood of you converting from pre-diabetic state to a diabetic state. And the only thing that happens on the downside is it costs some money to do, and it doesn't even cost a lot of money. So now there's legislation that's been introduced in the United States Congress to try to get Medicare and Medicaid to pay for these diabetes prevention programs. And that, along with the partnership with entities like the Y, and the Y is a valued partner, and we hope there'll be others who can offer similar programs as we go forward and expand this. But think about this. Notwithstanding the fact that most of you raised your hand that you like seeing a happy doctor, or at least you like seeing your doctor better when they're happy. Going to the YMCA is far more accessible for the average American, right? Anyone been to a Y in their lifetime, someone? So, okay. Everybody almost, or most. That is just America, right? This is not South Beach, Miami. This is not Hollywood, right? This is Americana at its best. Sweatpants, T-shirts saying all sorts of colorful things, hair isn't done. I mean, this is just regular America. It's not threatening, it's comfortable. What we need to do is find a way to get the physician's office in contact with them so we can identify the people at risk, refer them to a place where they can get that benefit of the program, and have a feedback loop back to the doctor who can participate in this. But fundamentally, it's not a problem solved in the doctor's office, it's a problem solved by lifestyle modification in partnership with society at large. I hope that sounds inspiring. We really are trying to make a big difference here, and we're doing similar things with the hypertension work. And the third thing we're going to really try to profoundly impact is undergraduate medical education. So the paradigm with which we train physicians today is essentially the same structure that a guy named Abraham Flexner created in 1912. It's 2 years of basic science and 2 years of clinical science. The structure of the container is largely unchanged, even though what's in the container has clearly changed a lot in the time since Dr. Flexner did his work. We need to change the container, and we need to change the content. The doctors of today and tomorrow need a different knowledge base and a different skill set to thrive and succeed, and to help you all be healthier and to help themselves be professionally sustainable and fulfilled. So the AMA in 2012, when we started this journey of these three strategic focus areas, went out and did a request for proposals. 84% of the medical schools in the United States sent in a letter of interest. That's not just a handful of people who think it's a neat idea. That's fundamentally the entire medical education community says we've got to do something like this. We invited 30 to submit proposals. All 30 accepted the invitation, and then we funded 11 medical schools at $1 million over 5 years. So $11 million over 5 years to seed fund these schools, and we created a learning consortium. And I have had the chance to visit some of the principal investigators at these institutions, and they pretty consistently said, thank you for the money, because there's nothing close to that in medical education for grants. But more than the money by far, thank you for this learning consortium we've created, where we brought together thought leaders across these medical schools around the country and are having them work together to solve problems and create new structures for medical education and new content to fill it. So the only one I'm going to highlight in this setting, because it's digital health, is Indiana University, which has a fully functional EHR set up like a sandbox, populated with real patient data that has medical students immersively using the tool to enter information, to practice on it, to incorporate it into their learning as a clinician, and to learn how to withdraw information from it that can help them provide better care for a population of people. Is that not what we want to do with electronic health records? It's not done prevalently, I'll tell you that. Lots of students aren't even allowed to touch the EHR because of fear of HIPAA and things like that. And I do want to touch on that one time. If anyone in here is the genius who can fix this, I'd like to meet you before I leave this conference tomorrow, okay? Complying with HIPAA is not a little small problem, it's a big problem. You've all heard of small companies like Target, Home Depot, Anthem, who've had data breaches, right? Who gets dinged for a HIPAA breach? The provider. Are the penalties like a multiple of 1 or a multiple like 3? Are there public notification periods if enough people are impacted, like take out an ad in the newspaper, go on television? It's a big, big deal. And so we want to embrace having information where we want it, when we want it, at the time we need it to provide care for patients. And we want patients to have access to their information. Let me say that again. Physicians are happy to have patients have access to their information. But it's a little oversimplistic just to say, put it all up on the internet and make it available when the doctor could have their practice put out of business because they get dinged for a HIPAA breach. So there's just a little inconvenient complexity in bringing some of these visions to life. Now, the AMA in this area is working aggressively as well. I'm going to pivot real quickly. I got 5 or am I? Nope, I'm done. So we're a founding partner of Healthy Way, which has Care Equality and eHealth Exchange, and eHealth Exchange is now the largest health exchange in the country. I mean, you wouldn't think of the AMA like that, would you? I mean, we're the founding member of some of these really innovative technology efforts. We have an incubator accelerator called Matter that we've partnered with in Chicago to try to bring innovators together to solve really challenging problems in the modern day world of venture capital and private equity. And we're doing a number of other things. So I'm going to finish with this last quote. I started with Darwin talking about those that succeed and thrive are the ones who can best adapt to change. Now I'll switch to Gandhi and just say Gandhi said, you must be the change you want to see in the world. I hope I've been able to at least give you some sense in this brief time I've had to talk with you that there are physicians out there who are excited and thrilled about the change, who want to embrace it. And my one ask for this audience would be you and your colleagues, don't suffer our bad behavior to the extent we exhibit it, because I know some of us do. But please help support us in our professionalism, because right now it does feel a little bit lonely, believe it or not, to be a doctor when everybody is blaming you, like a public school teacher, for why is the kid who comes from a home in a single parent home with no food, who comes dirty, who didn't get any sleep because they were having a party there the night before, why can't that kid learn and it must be the public school teacher's fault? Being a doctor in many ways, in many settings, feels a lot like that. Yeah. So to whatever extent we can work together, we will do a better job and we'll have a better chance for success. Micah, it's all yours. Thank you very much, everybody.
All right, Dr. Stack.